So we are both here at USU's Kaysville Education Center, which houses Extension and the statewide campus offices. We received a lot of questions in advance through our RSVP form, and Maren's gotten a chance to look at those and even structure her presentation around them. But we'll be including some of those RSVP questions, but we also want to focus on questions submitted here and in the live chat. So please keep submitting your questions. Don't submit them to me personally. I have a lovely team of people going through and just like feeding me the questions that should be asked next. So please, if you're submitting questions, don't send them to me in private message. Okay. But let's just get started with an RSVP question from Amy Kahn from Regions Blue Cross Blue Shield. She would just like to know more about strategies that help clinicians facilitate members into timely treatment.
Yeah, so this is an interesting idea. So in Extension, we are mostly on the education and community support side. And so we don't get engaged with the clinical side of the treatment services as much. But one of the really exciting models out there that I've heard about recently is called the hub and spoke model. And one of the things we have done is to make sure clinicians are able to get medication assisted treatment waiver training, because if we can bring treatment into our primary care offices, then that's going to help people get timely treatment, because we're going to catch people before they get too far down the road of dependence. We can get them medication assisted treatment when the doctor first notices the signs of a little bit of opioid misuse or overuse. And so if doctors in primary care are comfortable treating their patients with some really safe medications, buprenorphine is one of them, then we can get people timely care because they're getting it sooner. The doctors in primary care are noticing the problems, giving people the treatment. And it really is like diabetes and insulin treatments. It's this chronic illness that we need to catch, be aware of, catch it early. And then if we can get primary care treatments on board, then that's going to be timely treatment. And it's really hard to address timely treatment when a person's so far down the road that they've started to turn to street drugs as their solution, where there's been criminal justice involvement, where they're now waiting lists for the inpatient treatments for addiction recovery. So if we can do that timely treatment early in the process, that's going to make a huge difference.
Awesome. And now we have a question from Angeline Clayson. She's from USU, and she said she would like to know more about any community support programs, financial support for those interested in substance abuse programs, and how employers can best support employees and their dependents in this area.
In Tooele, with one of our grants, we were, there really is this sort of gap between people's medical insurance and their individual resources and getting all their needs met, like helping them with a short-term housing crisis or things like that. And so out in Tooele, we were able to get some grant funding that we call recovery support community funding. And so there are small grants that you can get that can address some of those individual needs. But that's a bigger problem. And so really just getting the whole community involved, reducing stigma so that there's resources and support across the community in a really comprehensive way might be one of the only solutions I can suggest in that regard. And employers can be part of that by making sure they have the mental health resources and sort of just a mental health friendly environment at their work as well.
Yeah. So we aren't getting any questions submitted in the chat yet. Maybe I scared y'all off. If you want to send them to Shalise McDonald, if you kind of want to be anonymous, you can send them to her. And then, but I guess now we'll move on to a question from Margaret Hostetter. She'd like to know more about resources for the homeless receiving,
Yeah, so it's a really good question because I'm sure, as you're aware, mental health disorders, substance use disorders really are overlay a lot of some of the other societal problems we have that lead to homelessness and some of the other really difficult situations. And that's not an area that we address a lot in Extension, but we do work with all our community partners trying to make sure people have awareness of the different resources, but that's a larger societal issue. And hopefully reducing stigma and getting people treatment earlier can help a little bit, but I am not the expert in that area, and it's a bigger problem that we really need to come together and address. I agree completely.
Yeah, yeah. Hopefully that helps Margaret Hostetter from Utah's Behavioral Health Planning and Advisory Council. So now Amber Braun from Overdose Awareness Utah, she would like to know more about aftercare following treatment.
So again, the USU Extension, we're really focused on the education side of things and not the clinical side. And so we don't get directly involved with the once individuals are in treatment. But aftercare is such an important aspect of getting people the support they need.
Sorry.
So aftercare would generally be after a person has a diagnosed substance use disorder and has received some initial treatment to try to address the condition. But part of what you need to realize in this is that, again, substance use disorders are chronic conditions. And so when a person leaves that initial phase of treatment, whether it's inpatient or a residential treatment center, the problem hasn't gone away, and they're going to need ongoing support. And so that definitely is part of what our community awareness, stigma reduction, it's okay to take medication while you're in treatment. All of that messaging is going to help. Like there's some people who think that if a person takes medicine for substance use disorder, they're just placing one drug for another, replacing one for the other. And we need to get away from that mentality. Again, we don't say that when a person's taking insulin for their diabetes. And so just supporting people through every aspect of recovery might make steps toward getting people the aftercare they need and getting them support they need in their communities, but that really is a larger issue.
Greg Bell from Utah Hospital Association would like to know, how are USU's programs integrated with local mental health agencies?
Yeah, so since we aren't on the clinical side of things, we connect with the local mental health authorities and agencies, often in grant writing partnerships. We sometimes offer some of our education classes directly in their centers. I know that's happening up at Bear River Mental Health, where we're able to bring the naloxone trainings and pain education and nutrition education and other sorts of programmings into their treatment centers because we focus on education and getting that information out there. So you'll see some of those partnerships. But because we're engaged in the communities, just about in every community in Utah, Extension is working with those local mental health authorities to make sure that we're connecting on resources and that the education we're doing is supporting those agencies. I think that's our main point of collaboration. And maybe there'll be more in the future as the health and wellness arm of Extension expands.
Okay. So Miguel Rivera from Regions Blue Cross Blue Shield of Utah would like to know, in your research, does data suggest that the opioid substance abuse problem disproportionately impacts underserved or minority communities?
So health disparities are something we see in general disproportionately impacting, like health in general is more challenged in those underserved communities. And absolutely that is true in mental health and substance use disorder areas, as well as general chronic conditions and other areas. We've been doing a lot. You heard Susie talking about the outreach they do to their underserved communities out in her area. But a lot of the like rural areas are also considered underserved populations. And so some of our outreach has been specifically to rural citizens, and yeah, that's absolutely an area that we serve. So we basically have to do needs assessments in each community and figure out who are the people that need the services the most. And those are the kind of grants we apply for to try to get services where they're needed.
Yeah, yeah. I went and I met Susie, and that's like, I'm the one who made that video, and just seeing her talk to all these people from all these different organizations who knew her, because she's just like connecting them to the resources and trying to just get like, oh, you need this, I can get this person over here to provide you that. Like, it's pretty impressive, the kind of work happening out there. Oh, and Susie is here. Hi, Susie. So Robin Hatch from Northeastern Counseling Center would like to know, is it helpful if we are able to, it is most helpful if we are able to access the data discussed down to a local level. Why is that sometimes difficult?
Oh my gosh, I would love to get more local data because then we know better who needs the help and how to address it. And it's been really hard. It's my entire time as a faculty member. I'm trying to get data from the state that reflects more the small area and local areas. It's been really hard. I haven't gotten much. And part of the problem is that as the numbers get too small, it can potentially be identifying for individuals, and they need to protect the data at the state level. The state's been amazing. They have an opioid dashboard. You can get county level data from there. But I totally agree. It'd be nice to have data down to a more local, minute area, and we'll keep working on it.
Okay. So
that data really helps us with our grant writing, and I love grant writing. So yeah, the more data we can get, the better.
So Allison Heffernan from the Utah Health Policy Project would like to know more about the opioid epidemic and incarceration rates.
Yeah, so one of the things you see is that people who have substance use disorders start to have more criminal justice involvement. So there's absolutely an impact on incarceration rates. But one of the areas we're most concerned about is, in that graph I showed you earlier, is that because individuals in incarceration have been away from the substances that they tend to misuse for a period of time, their level of tolerance and dependence drops. And so if they go back out on the streets after and as they're released, use the same level that used to be safe for them, it's now no longer a safe level, and their body's too responsive, and it can create an overdose. So that's one of the main areas we focused as we try to support people who are criminal justice involved. But peer support programs are also awesome for supporting people who have criminal justice involvement. A lot of our peers have had criminal justice interactions, have felonies on their record. They understand the system. So that's one way to give more support to people. But absolutely, there's an overlap between substance use disorders and criminal justice involvement, and we need to do a little bit more to try to address it.
Yeah. Kara Swenson would like to know, has HEART needed to pivot their work/outreach during the pandemic?
Yeah, so we definitely shifted to a lot of virtual trainings, but to some extent, with the community engaged work we do, we were still, producing the community fact sheets. We were, some of the treatment centers had closed down, some of the internships for our certified peers disappeared for a period of time. But in many ways, we were able to reach more people through virtual education. So it hasn't necessarily been a bad thing. We also did a little extra grant writing during that time. And so there's been a little bit more opportunity there to serve. So overall, COVID has not harmed our efforts, but we did adapt and change a little bit.
Yeah. You mentioned briefly the other pillars of the HEART initiative and focused on what your work is in it. Can you spend a little more time talking about some of your colleagues' projects and what they're working on?
Yeah, so we have prevention as one of our pillars, and so much of our work falls under prevention. There's also stigma reduction, and so a lot of my colleagues are engaged even more in stigma reduction than I am. For me, it's more of a secondary outcome of some of the work that we do. As we get more peers into the communities, as we do more pain education, stigma reduction happens around that. Others are doing community dinners and really direct outreach to communities to bring up conversations. There was a project that was done called the Opioid Narratives that we collected people's stories of recovery and the opioid crisis in Utah, and digitally archived those and have those and told those stories in some community conversation dinners, so that people, so that it wasn't just somebody off in Salt Lake in a back corner, but it was people in your community that you saw and you understood, that creates some of that better awareness that can create change. So some have worked on projects like that as well.
Yeah. So HEART is currently focused on the opioid. I'm trying to read this one. HEART is currently focused on the opioid epidemic, but it is about all types of community health. Exactly. How are you hoping to grow or your focus in the future?
Yeah, so one of the areas I like to serve is our aging population. So I've been able to do that with pain education, because older adults have a little bit more pain. So our pain education programs have been really helpful. And they also have higher risk of opioid overdose as there gets to be more medications and medication confusion. So it's been a good tie-in, but I really like working with the older population. And so cognitive strategies for reducing memory loss and Alzheimer's risks and falls risks are some of the areas I really enjoy. Some of our others have worked on like body image projects to reduce some of the fears and concerns there, especially as young people have more anxiety and depression. There have been a lot of mental health projects. We do suicide prevention, mental health first aid kind of trainings. So our group is very involved in that area. And there have been several who are very involved in physical health. I mentioned the Living with Chronic Pain series that we work with, but there's also one called Living with Chronic Conditions and Living with Diabetes that several Heart faculty members are trained in and provide to their communities. So lots of different areas around health.
Yeah. Best case scenario, draw us a picture of what an optimal system for opioid harm reduction would look like in Utah. What type of resources would we put into it? What type of connections and partnerships would we need? And what type of results do you think could we see? That's a lot of questions, but
that's a lot, and it would be comprehensive and big. Some of the steps in getting doctors be more aware of their prescription practices have obviously been helpful, but it was some recent evidence came out that if doctors, there's this controlled substance database where you have to check before you give an opioid prescription if the person has been getting them from other doctors. Anyway, so that's one of the tools that they use. And there was some information that came out recently from the Journal of American Medical Association that did a sort of an analysis of use of those systems, and they call them prescription drug monitoring programs. This is way too much detailed information. But what they found is that if doctors just sort of cut people off, if they don't do this sort of comprehensive care model when people are starting to misuse opioids, then checking one of those databases actually resulted in more deaths and more negative outcomes down the road. So you really need a comprehensive where the doctor is addressing the need, ideally that hub and spoke model that I mentioned, where if the primary care doctor sees the need early, addresses it in their clinic, where we don't have to refer someone out where they may or may not show up at that specialist office, but we can treat them here in clinic. That's going to be a part of the comprehensive model that we need, where it really is viewed like diabetes, where it's just a primary care concern that we deal with in our office. More of those safe medications, buprenorphine, that can support people when their bodies have become sort of a little too used to the opioids, and they have those long-term neurological changes that just make life really hard if you don't get support. So that's going to be helpful. Community support will be helpful. And you're always going to have people who end up on that addiction spectrum with some of those criminal justice problems, with homelessness. And so anything we can do around harm reduction to support people as they get into those areas until they can make a choice for recovery would be helpful as well.